Well, hello, everybody. Thanks for tuning in to the next episode of the 260. I am Taylor Finn. I got my co-host,
Caitlin Carper.
Hey.
Hi, guys.
And I got some subject matter experts in front of me.
The Meoff brothers.
I have Tony Stimpson and Barry Vancamp. Very excited to have them here. If any of you have been around EMS in this area, they're the goats. These are individuals that have substantial EMS experience and a lot of wisdom. And so I'm very thankful that they can come in. And they're also partners for how long?
23 years, except for a 6-month sabbatical when Mr. Vancamp thought it was appropriate to try and get up before the sun came up by a few hours.
Ooh.
And it didn't work out so well, so he came back to
That was a
continue.
stint at 3 o'clock in the morning.
Yep.
Body didn't like that at all.
Well,
Those are stupid
His
hours.
Organically.
day started at 4 a.m. I think
Yeah.
mine started at 5 at that time.
That was stupid.
And I didn't have to say anything. He figured out that his body told him to come back to Tony.
That and all the notes I got from Mr. Auker saying, this is like your last and final for not being here on time.
you just were in late, or what happened? Or-
Yeah, dude, trying to get up that early? Are you kidding me?
It's pretty freaking early, yeah.
Well, I had, at the time, I had 3 kids.
Little kids.
Yeah, those were young kids. Trying to get them to everything they wanted to do and then get home, get to bed. Are you kidding?
Mm-hmm.
That was insane. Of course, and at that time, too, I was kind of living on undiagnosed sleep apnea.
Oh,
So,
that would complicate things.
yeah. And
Yeah.
not to mention the sleep apnea, but then the wife jamming me in the side, you're snoring.
A lot of love there.
Yeah. She's like, hey, breathe, dude.
Yeah.
Breathe. I got 3 kids. Don't leave me alone with them.
Well, this is why you never want to marry a respiratory therapist and have sleep apnea, because you wake up with them trying to do a jaw thrust on you.
Oh, my goodness.
Just practicing skills. Don't mind me, sweetie. Right on. Well, so we got Barry and Tony here. Thank you for your time and coming in. I appreciate it. You guys both have other things going on in your life, so thank you. I want to get to know you a little bit, and so that our audience can get to know you too. Tell me a little bit about, I guess, Tony, if we can start with you. How did you get into this? How are you in the position that you're in today?
Wow, that's an interesting question, but thank you for having us today. Appreciate it. So my EMS career started, my grandfather was a firefighter out in Massachusetts, just outside of Boston, in a small town called Abington. So public safety kind of understood it, but like back in the day, for the old timers that are going to listen to this, they had a firebox system. And he had a house gong in his house. So anytime a box was pulled in the community, this bell would gong. And I'm like, as a little kid, it's like, oh, this is cool.
Whoa, what's that noise?
So kind of got attracted that way. And you couldn't get in the fire service until you're 21. So when I was 16 years old, I live in Decatur. I still live down there. I walked into a local lumber yard. And I had been trained in CPR as a freshman in high school. And this gentleman was in cardiac arrest. It was actually the owner of Arnold's Lumber in Decatur. And so they're there and they're not knowing what to do. I knew CPR, so I did CPR, and this guy survived.
What?
So it was kind of cool way back in the day, and this would have been in 1979 or 80. Then let's go move past that and move ahead. So I started my EMS career in 81, and then became a paramedic in 1986, and I was probably a paramedic, I don't know, about a year down there. And we get dispatched to Arnold Lumber on a cardiac arrest, and it's the same guy.
Oh,
And
my
And as
goodness.
a paramedic, I couldn't save him, but gave him roughly about 10 more years of his life, somewhere in there, 8 to 10 more years. But it's interesting. So I do that. I'm a paid on-call fireman down in Decatur. I've been on Decatur Fire for 40 years. Just started my 45th year going in. I'll be starting.
Yeah.
And I still serve as the paramedic on the Allen County Sheriff's Department SWAT team. I used to be the chief deputy coroner in Adams County, but hung that up in 16 when I came over to Lutheran full time. I was one of the original hires for Lutheran Air with Mr. Vancamp back in 2004.
Yeah, 2004.
So we flew we didn't fly together because they wouldn't let paramedic fly. You had to fly with a nurse.
We'd have ruled the skies.
I was going to say, like, that would have been so cool.
Yeah.
We do allow that now to fly nurse, and or or paramedic if, we can't get a shift covered. But so I do those things. It's fun.
Yeah.
I've never looked at this as a career. This has always been, hey, let's go have fun at work today. It's just fun.
It's a good mentality to have. I should probably tell myself that sometimes.
It is. It's fun. When you go to work and you have fun and, you learn some things. You're always learning. Every day you learn. When you quit learning, it's time to check out of the world. So that's about it in a nutshell.
All right. Mr. Vancamp, how'd you get into this? How are you here today? What
Well,
happened?
mine isn't quite that exciting. Basically, in high school, I wanted to go into the building trades. Teachers talked me out of that. I liked earth science, hunting, fishing, went to school for law enforcement conservation, applied for jobs. 2 places asked me, they said, do you have any EMT experience? I'm like, no. So I thought, I'm not going to say no a third time. So I signed up at Trod to become an EMT. Next thing I know, I got a full-time job at New Haven, from volunteer to full-time job out at New Haven, and I'm in paramedic school. I wake up one morning on my 36th birthday, and I told my wife, I said, well, I guess that college degree is worthless. So yeah, it was just happenstance that I stumbled into this. At no point in my life, until I was actually in the career, did I think to myself, this is for me.
What'd you study? You said
Law enforcement conservation,
You're going to be a rabbit cop.
treetop cop, all those things.
Oh, gosh.
okay. Some terms I haven't heard before. Right on.
And later in life, what did you want to do? Drive dump truck.
I still want to be a dump truck driver when I grow up.
I mean, that's all I
gosh.
wanted to do when I was a kid. My parents got me a calendar of dump trucks. I was so obsessed. I mean, they are very cool trucks, but I don't blame you. Yeah.
Triaxle. For some reason, I'm really obsessed with that third axle.
Oh, gosh.
Really gets you going. So you mentioned the degree thing, and we said it in a few other episodes, just how like asking similar questions to people who've been where you are, like it really wasn't what a lot of people planned. It kind of just fell into place that way, and like things aren't linear. You kind of just, I don't know, you start trying things, then eventually this is kind of working. I kind of like this. I'm having fun at work. Like maybe I should keep doing it.
Oh, yeah. I mean, it was, to this day, I can remember my first run. Dennis Spillers and Doug Geller were the medics, and I was that third person, and we went out on a motor vehicle collision. And it wasn't even that bad of a collision, but I was like, man, this is a blast. And then just kept going.
That makes me think my first day on an ambulance was the 4th of July. And I just assumed every day is going to be like this. This is like TV. This is crazy.
Everyone's blowing their hands off.
Well, that was not every day, but I would say pretty regular for 4th of July specifically, but kind of an outlier of days to start things. But yeah, lots of fun. You talked about how you got into this. Why become a paramedic specifically? Like, was advanced an option? Was basic? Were EMRs things? Like, why go to paramedic? Why go to paramedic school? It's not that easy, and it usually puts a lot of stress on the individuals. Like, what made you guys want to do that?
In Allen County, if you were an advanced EMT, the only thing you could do is put a combi tube in, or I'm sorry, it wasn't a combi tube, it was a PTLA.
Pharyngeal tracheal airway.
Yeah.
It's in this day and age, that's what we would consider a supraglottic airway.
Mm-hmm.
Yeah. And you could operate an AED.
So
That was
You
an
could drop
advanced
a
EMT.
step up from an adjunct, as well as operate an AED.
Yeah. That was it.
And drive the ambulance, lights and sirens.
Oh, and we're doing that good. So yeah, and you would have paramedics coming out from the city, because at that time, the only paramedics in Allen County were the Fort Wayne medics. And they had contracts or deals that they went out and assisted the county. And sometimes those guys would come out. To say they were asses would be a little bit of an understatement. And you didn't want to give up your patients to those guys. I'd do a better job than they would. So you had to go through paramedic school.
Joe's a jerk. I want to hand one more person off to that guy.
And Tony will tell you. I mean, how many people were in your class?
My paramedic class, I took mine, I think, at Adams County in 85, 86, because I got hired full-time in 84, and the requirement was that you had to successfully pass a paramedic program, which Adams taught. So I started out at Adams County EMS, then came up to it was Mercy Ambulance or the TROS system, part-time in 87 and then full-time in, I believe, 92, I think, somewhere in there, I don't know. I had a whole fistload of guys in my paramedic class. I probably had 16, 18 people in my class. I can't tell you other than I liked EMS and it was kind of cool, but to tell you, why did you become a paramedic? Well, I needed a job. I was working at the time. I worked at Strick in Monroe making semi-trailers when I got out of high school, working part-time as a basic EMT, and then went full-time in 84 because I had been laid off at Fleetwood, which Pacero at the time, making RVs. And I'm like, okay, I got to do something. So I applied. And they used to have a South EMS and a North EMS, and the South was all volunteer, and the North half out of Decatur was full-time. So I was the only person that lived in Decatur to get a full-time job because there was so much pressure on them to hire people from the south end of the county to work in the EMS system. And so I had to go to paramedic school with all those folks, and I knew them somewhat. It evolved, and it was different at the time.
Why not?
Well, I guess the big thing was I wanted to be a career firefighter. I mean, I turned down a full-time job at Decatur Fire. I could have been a full-time fireman back in the 90s. I'm like, I'd lose too much money. But back when I was really young, my goal was I was going to move out to New York City and become a firefighter out there. My goal was to work on Rescue One, the busiest rescue company in the world. But I never had enough balls to move out to New York. Probably a smart thing nowadays.
For sure.
I'd have never met Dr. Vancamp.
Thank you. Thank you very much. So when I applied for paramedic school, there was set criteria that you had to meet, very similar to like the police academy or the fire system. You had to go through, we had, I think, 2 interviews. You had a clinical interview, like a peer interview. You did a physical agility test. You had to pass the state EMT exam. You had to pass, they took the highest 20 scores. So it wasn't like a minimum. They just, the 20
You
smartest.
had to do as good as you could possibly do.
Yeah, my class was 20. I probably scored number 20. What do you call the guy who graduated last
Hey, bees get
in
degrees.
doctor
dude.
school? Doctor.
Doctor.
So, we go through that. I mean, there's still, out of my class, there's a significant number of people that are still in that industry because you had to have 20 hours of patient contact to even apply. We had to go back through and dig out the run numbers, on-scene time, and at hospital
They're
times.
checking receipts.
Yeah, they wanted receipts. So we did that.
Huge
Like-
check. There was a huge check and balance.
Yeah. Doug Call was in my paramedic class. Dr. Matt Sutter was in my paramedic class. Kurt Chivers, he's still in it. And I don't remember Deb's last name, but she worked in Huntington. So, but yeah, there was a lot of people that remained in EMS at that time. And it, like I said, it wasn't something that you came out of high school and you said, oh, I'm going to go into that. It was pretty stringent to get into those.
So
classes.
there's one person left out of the basic EMT class that I went to school with that's still functioning now as a paramedic in a different role, is Greg Engel. Greg Engel and I went to EMT school together.
Can't stand that guy. Jeez.
Greg Engel.
Just kidding. Greg's literally the best if you never met him.
What is a thing that you guys did when you got on shift that no one really knew about, that only you two knew about, that was kind of funny? It was like your routine. You listened to a certain song going to a run. You always listen to country music.
Always get Hardee's on Wednesday. Something.
Yeah.
We were very routine.
Yeah. What was your routine?
And I guess there's probably nothing that super stands out is that we did anything. It was kind of, Tony came in earlier than I did. So he'd get the truck checked out, do that kind of thing. I'd come in, throw my stuff on, half asleep still. He always liked to take the first patient for probably the good first 15 years.
Or more.
Yeah, of our career. It was his thing. It was like, I'm
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 first out to shoot because we did the opposite. Most people, if you took the first patient, you drove. I didn't want to drive first. I wanted to get comfortable and just kind of do my thing. And so it worked out.
And then in the evening, and this was kind of an untold thing, is I was the kind of the freak that I cleaned the trucks every night. We bleached everything. And a little bit of the smell, I think, probably bothered you a little bit with that bleach. So he'd go do the paperwork.
And any blow-ups or anything ever? Or no, you guys just...
No, I think we would disagree on some stuff, but it was always an adult conversation that we had, because you're not gonna get along with everybody in your life, but you have to figure out, is this a me problem or is this a them problem?
It's actually very wise.
And then working through situations. I mean, you stop and think back in the day when they told EMS way back in the day. So this is 1981. When did you start EMS? 85?
87.
87. Oh, geez.
87 or 88 I started.
I think 87. Because you were at TRA. I think we worked, first time we ever worked together was we were both part-time. I wasn't full-time. It had been probably early 90s.
Yeah.
But you just work through situations. You have this, you have that. We got along well. I was more into some of the music stuff, but Mr. Vancamp got me going on Rush Limbaugh. Talk radio was where it's at. To this day, I have to listen to Wobo on the way to work because I want to know what's going on. Because my lifestyle has changed from a street paramedic to now an educator. So my priorities aren't the Weather Channel at home, keeping up on the newspaper, because the newspaper provides you with one thing in EMS. What is that? The obituaries, to see who you don't have to haul anymore.
To see which regular is no longer regular.
That's messed up, but you're totally right.
But seriously, so you look at that, and then the camaraderie that not only we had, but you posted an engine house in Fort Wayne, because I did, between full and part-time, I did 29 years with TRA. But you develop a lot of friend relationships with these firefighters and some of the old-time guys that, I see. Unfortunately, when Battalion Chief Aker was killed, I went to the viewing, and I'm like, man, it was like old home week. I could stay there for 5 or 6 hours and just talk to all these guys, like Derry Polish stood out as one of them. And I'm like, that was fun times back in the day, because you could get by with a lot more than what you can now. I mean, now if you turn sideways, they know you turn sideways because they're tracking everything. And back in the day, the shit we pulled that we got by with.
Cursed GPS.
Oh, gosh.
But it was fun.
The runs that you have jumped.
Oh.
Or escaped.
No, you didn't really. We never really tried to get out of anything.
Back in the day, we did a lot of, they would send a truck, say, to Parkview, Randalia, before Parkview Regional or when it was called Parkview North were built. And if you got in the inner loop in the city, like between downtown, St. Joe downtown, and Parkview, Randalia, you're going to do transfers. And they would be sending trucks over, and I'm like, we just pulled in. I'm like, just give us 10 and we'll take that run for you. I don't know how that looks now. I've been out of the system. I mean, you could probably talk to that, Barry, but you just did what was right to help out your coworkers. And at the end of the day, it was a wash, because if you're in the loop, you're in the loop. There's nothing you're going to do to change it. You get to a north post, or we wanted the east post, because, man, you can sit up there and it's going to be quiet. And if it's your time to make runs, it doesn't matter where you're at, you're going to get a run.
Yeah.
And you're thinking, oh, this is never going to end. But then we had time where, you played camp out. I mean, in my history at TRA, I've never been shut out. There are people there that have not made a run in 12 hours. I never had a shift ever, full-time or part-time, that I
didn't make a run.
We were probably close one day.
Yeah, I never got shut out there either.
But I couldn't take it, and I volunteered us for a run. It was like, I think it was 2:30 in the afternoon or something like that. We hadn't done anything down south. And Mr. Stimpson, I don't remember if he was in the back or whatever, but I came up and I'm like, Medic 3, we can take that. They're like, oh, okay, if you want it. And I'm like, oh, my gosh, we got to get out of here.
That's why I left Adams County EMS full time to come to TRA, because I wanted to be busier. You want to be busy because idle time kills you. You're going to get in trouble. You're going to make poor decisions. I got in trouble more times in my EMS career working the streets because of idle time bullshit that I pulled than any critical situation type decision I ever made. I never got in trouble for that.
We made great decisions under pressure. Take that pressure off. We made some sketchy decisions.
Yeah.
Like, okay, so when there's snow piles behind Southgate and you're bored,
oh, no.
don't get the truck running 60 miles an hour and plow into them.
Oh.
Don't do donuts in the back of a parking lot at Southgate and then have a student with you, and then your boss, Craig Miller, asks the student, well, how's your day? It was great, man. We're in the back of the behind the Kroger's doing donuts in the ambulance. And I'm like,
with straight faces.
Yeah.
With straight faces.
Yeah.
Tony and I are sitting there filling out his paperwork. Who'd you ride with today? And Craig just turned around and walked out the door.
What, you're going to tell
Yeah,
me you went sledding with the backboards?
Yeah, I was like,
Oh.
I don't know, you went sledding.
I
no,
I didn't do that. Our biggest thing that we did back in the day, and I think we can talk about that, is the Peddler's Post with New Haven.
That'll teach you to mess around with us.
So there used to be an ongoing thing back and forth that you'd mess with somebody's truck. So the big thing is they would take the defibrillation gel, which you don't have anymore because they have pads, but we had manual defibrillation, and you get your gel out of your truck and you would smear it underneath the door handles, on top of the steering wheel, on the wiper blades, or put it on the seat and write a derogatory comment, maybe a profane comment. So when they sat down, if they didn't catch it, it would dry and it would be on their hind side, and you'd see this on there. So you would do that stuff, and then they get back with you, and somebody might have emptied our entire truck, every bag and everything, out in the back of the truck, took all the bags and stuff and just laid them out there, and then took our cot with the extended legs. Before you had the strikers, we had the Furno 28s. So you just lock the legs out so it's standing up, you put it in the truck, and then you'd hook it on and lock it on the grab bar on top. So it was like a pendulum. We found a dead bird.
Yeah, the dead bird really sent it over the top.
It's these people from New Haven.
Yeah.
They're harassing us.
It's crazy.
Absolutely
We were
They started it first.
Savages.
minding our own business. Okay. And there was this bird laying in the parking lot of the ambulance bay. Been there, day or two?
Mm-hmm.
We're just moving through there. And all of a sudden, the bird's not there. And you're like, somebody cleaned, no big deal. You probably didn't even notice it. But we're sitting in our truck going, something's dead.
Oh, God.
Something died in here.
That's nasty.
That
Oh,
kind of funny.
it gets better.
So we start going through this truck. Here's that bird underneath the passenger seat. Huh.
I can remember Mr. Vancamp's expression and his comment. Mr. Stimpson, this is what you call game on.
We get this bird out, and we're stewing on this for like a couple days, because we want to light the candle on the cake here. This party's going to end right here.
Oh, God.
All right.
And it did.
So all of a sudden, we get this idea: we're going to put their ambulance up for sale on the Peddler's Post.
Oh, no.
We call the Peddler's Post. We leave the message. Ford F-350 Econoline panel truck would make great camper conversion. $3,500. Call after 11. Work second shift.
And New Haven EMS's quarter number.
Yeah. We gave him the number to the business. What was it? About 2 or 3 days after that went public, we saw Kurt Chivers at the Parkview. We said, "How's it going, Kurt?" He goes, "Oh my gosh." He goes, "We're getting all these calls. Somebody put our ambulance up for sale."
Who would do such a thing?
Yeah. So he and I just start laughing. We're like, "We don't know nothing about that, Kurt." Guess what? The party was over.
We saw him, I don't know, 2 or 3 days later, and he's like, "We give. We give." I said, "What do you mean you give?" He says, "We know. We give. We're done. We're not going to mess with you anymore." I'm like, "We didn't do anything. Get rid of it. Just please get rid of it." So it went away, but it was probably a week of terror for them.
Yeah.
Oh,
Because he
God.
put after $3,500 or best offer.
Oh, yeah. This
of course.
This truck was only like 4 or 5 years old. So for $3,500, oh yeah.
Yeah,
Every hillbilly in the world called to get that
I'm
thing.
trying to think, like, how much is that ambulance worth at that time?
Over 100,000.
Yeah,
way over
Are you
100,000.
He said, they had people calling saying, "No, this is EMS. Are you selling this da-da-da-da?" And they're like, on and on and on.
Yeah.
And they couldn't get rid of people. I'm like, we win.
Did people go to the station? I could imagine people going to the station and be like, "Hey, I want to check out your
We
ambulance."
never put an address, just a phone number.
Yeah,
Oh, yeah.
it was just a phone number type deal.
That was a tertiary plan if they continued their assault. And phone's not working. Come see in person.
Yeah.
Make sure to ring doorbell after 11.
Well, because the funny thing is, years later, I told, I think it was Matt Lorraine, had told me a story that it happened to him that somebody had put shrubs in the Peddler's Post. You dig. No phone, just gave the address and you dig.
Oh, God.
That's funny.
Let's talk about in EMS as a whole. EMS has changed dramatically If you stop and look, when I started in EMS in 1981, you had everything was reusable. I mean, when I worked at Adams, we would help in the ER. So they had glass syringes and needles that you would clean, you'd wash, and you'd put the needle in a 4x4. And then you would take the glass syringe and wrap it in one 4x4, and it would go back and get autoclaved. They had off orange colored endotracheal tubes. You would rinse those out, and they would autoclave those and reuse those.
I'm ignorant. What does that word mean, that autoclave?
Oh, it's a cleaning machine.
Okay.
It's a sterilizer.
Sterilizer. It's
Gotcha.
Yeah.
like all your central supply stuff for surgery and stuff like that. They just move it up to a specific temperature, and that sterilizes, kills
It's
the
a
green
it's a
stuff.
steam. It's kind of like a steam thing.
Okay.
And the whole process is, and I don't know if Adams County did this, but I know Lutheran was doing this in the 80s. They would fold it up in like a napkin kind of thing, and then they'd put this tape across
they
the
still
seam.
do.
And then you'd put that in there, and when that tape turned color, it had been at that temperature.
It's
long
like
enough.
one of them there Jiffy Bake Ovens, or the one of them turkey things you put. It pops out when there's a
turkey
done.
baster there. Yeah,
Yeah.
that's what it was.
Then you looked at portable suction. We carried Lairdals, the gray suctions, which were absolutely
Worthless.
horrible because you would have to clean those out. Well, back when I was a young paramedic, I was a gagger and a puker.
Mhm.
So you'd open that lid up out of there, and I'd already be gagging pretty
Yeah.
bad.
Pretty ripe and it's sad.
Yep, you dump it. You had to clean your BVMs because you reused those. Everything was reusable. Everything. I can remember them making short boards. They went out and bought marine plywood and then etched them out and cut them out to make short backboards. And we had to use short backboards, and they were a nightmare to use because you had to run the straps through, and it was like, it's not like the KED.
Probably heavy too, I imagine.
They're heavy, they're
Yeah.
cumbersome, they just didn't work.
They were better for giving the truck traction.
Oh yeah, when we got stuck, used stuff. So, but you stop and think about that, and then the transition. CPR was, 5-1 or 15-2. That's what it was, and then they changed over the years and whatever. You stop and think about it now, how CPR looks nowadays. I don't see a lot of changes coming. I really don't. I think they found something that they're successful with. They didn't understand the increased interthoracic pressure, what it takes to move oxygenated blood. CCR resuscitation is going to the wayside a little bit. Current studies are out there that are saying that you still need to probably put a BVM on and give some passive oxygen or bag them every once in a while. Regardless, I mean, there's some things that need to be done, but CPR, it's not going to change. And then we have pneumatic CPR devices with Lucas and auto pulse. I think that's huge. You're looking at that. Back in the day when you got hired at TRA, the mark of a good paramedic, when I got out of school, if you could intubate, you were a good paramedic. And I think that's wrong. I think nowadays we're looking at things a lot differently because what you see is trending is the mark of a good pre-hospital care provider, because we have EMTs, we have advanced EMTs, we have EMRs, we have paramedics, we have nurses that work on the critical care side of things. And so I call them all providers.
Yeah.
How do you manage the airway appropriately? And it doesn't mean intubate. It means, did you ventilate and oxygenate? Because we never used to, give me a BVM. Hook it up to 15 liters. There's differences. There's nuances that we're learning. We as providers, like Barry and I and some of the other veteran folks out there, what are you doing? How does this look? What do you want out of this? Because we talked back in the day, it's like, whatever you do, you have to have a reason behind what you do and why you're doing it. Why am I starting the IV? Well, they may need fluids, they may need medications. But why are you doing what you're doing? There has to be a reason behind what you do. And they needed to understand that. Because if you got an audit, you needed to explain that.
Yeah.
But if you understood that and that's how you lived and your brain functioned, it was easy for you. Well, why'd you do that? Well, da-da-da-da-da, and you're done.
Yeah. Any more questions? Yeah.
Exactly. And it wasn't being derogatory towards an audit. It's just, it is what it is.
Matter of fact.
Exactly. And then I have some new pushes that I'm pushing out that I think are important. And I think the big one now from an educational standpoint, because I don't work in the clinical setting like Barry does. He's out there day in, day out. I do some first responder work with Decatur Fire. And then I work our trucks. I fly a little bit clinically. I probably, if I'm on the helicopter 4 times a year, that's a lot. I'm on the ground trucks more than that, but we're not doing the 911 side of things. But I would love to have the knowledge base I have now and go back and work at trial 20 years ago. I would be hands down so much better. And I don't think I was a horrible clinician, but I think every day you learn. And when you quit learning, it's time to leave. But now it's like, look at the patient and look at the monitor. What is that telling you? And I'm teaching that. I'm building a PowerPoint on that because to me it's so important. And I've learned a lot. When we talk about a gentleman that we know is Dr. Tim Pullman. He's a retired trauma surgeon. He was a track surgeon at Indianapolis 500. And he comes up, he still teaches and helps us do some stuff. But just some of the things that he talked about and he discussed, and you're able to pick somebody's mind. He's got a brilliant brain, brilliant. He knows more about blood than any 3 people. He is that intelligent on blood. He offers a lot. And he said, well, when somebody comes in as a trauma victim, everybody's all freaking out. The new people, it's like, I don't know what to do. I'm not sure how to start. Well, you got to start somewhere. Look at them. What do they look like? What's the patient telling you by not saying anything? What's their color look like? Mm-hmm. What's the texture look like? What's their breathing? Fast, slow, regular, or irregular? But what about perfusion? Nobody understands or takes perfusion seriously. It's like, I got to get a blood pressure. No, you don't. Do you have distal pulses? Are they intact? Are they fast, slow? Are they strong? Are they weak? We use the word thready. A lot of people don't know anything about thready. Keep things simple. Make them easy to understand so that people can process. Because how you process, or Caitlin, how you or Barry, we all process a little bit differently. I have the abnormal brain. You have an abnormal brain too?
Clearly.
But you look at that and it's like, what are we trying to accomplish here? So the patient's telling me this, and this. The monitor's telling me with the pressure that's low and pulse ox. Everybody's like, oh, pulse ox. What do you think about pulse ox, Mr. Vancamp?
Oh, don't get me started on that. So this is, Tony and I can remember, it used to be in the old days. Don't treat the monitor. Treat the patient. Covertly, medicine has gone to treating numbers and not patients. Brought in a patient one day. Patient has an SpO2 level of 88. I think it was about 88%. She's calm. She's breathing normally. She's not tachycardic. She's not tachypneic, alert and oriented. Doctor says, how long has she been hypoxic? And I said, who said anything about hypoxic? Well, her sats are 88%. Machine could be wrong.
What's her normal? Are her hands cold?
But she does. She's not,
yeah,
she's showing no signs of hypoxia.
You're exactly right, and that's once again, like Barry talks about it. If I touch somebody, I'm going to know. Do I have a perfusion problem? The stats could be off. Are they cold? That could be off. Do they have Raynaud syndrome? What's going on that's attributing to this number? I hate pulse ox. Tony Stimpson hates pulse ox.
Mark it down at this time. Tony Stimpson hates pulse ox.
And I'm going to tell you, it's really simple. End-tidal's where it's at. It's a live number. Pulse ox is 2 to 3 minutes behind, and then you get people that get hyper-focused on, maybe we need to change the probe, the finger probe. Maybe we need to do that. Put it on the air. Do this, do that. How about you take care of the patient? The patient's telling you something. And I'll just say it, and I tell people this all the time. If the patient looks like shit, they're shit until proven otherwise. They're telling you something. Get into using the word peri-arrest. Guess what? I'm going to die if you don't do something. But people are like, well, they still have this or they have that. No, they're telling you something. Their pressures are dropping. Everybody's hyper-focused on MAP. You can have soft MAPs. Normal MAP, 65. We want a little bit higher if you have a traumatic brain injury. So we're looking at these things and it's like, truly, what do we want out of this? We want good, strong clinicians that can make good clinical judgment out there. But the problem we have is, I need to share, Barry needs to share, Caitlin, Taylor, we all need to share our experiences so they get better. Because you look foundational-wise, people are building foundations. You're still building yours. You're still building yours. Barry and I are still building ours. But my foundation might be taller than yours because of the experiences that I had. Mm-hmm. My job is to help them in that trade to build that foundation, to make it solid, more solid, and build with the experience. And hey, I had this and it didn't work. I share more of my failures than I do my successes over the years I did, because you're going to learn from your mistakes. And we need to have that. We need to have that ability to share weaknesses and, this didn't work and this is why. So don't do what Tony did. It's important that we do that. We have to share. And Tim Pullman, Dr. Pullman, I'm going to let you listen to this on Spotify when it comes out, he said something that made a lot of sense. Prove a couple of things. Prove to me that you don't have something going on versus prove to me that you do.
Goes back to what you said at the very beginning, ALS until proven otherwise, basically.
The old adage, a smart man learns from his mistakes, a wise man learns from others' mistakes. I tell people say, I'm working with a lot of young people now, and they say, how did you get to point A? And I'll tell them I've made a lot of mistakes getting here. I tell new people, like Tony said, how you handle a run today will not be the same way you do it 6 months from now. And then in 6 months, you'll do it something different. A lot of my assessments are the same. I handle most situations pretty much the same, but I'm always learning, tweaking, making it a little bit better, a little more efficient, cleaner, faster, that kind of thing. And going back to what, Tony had said about like the map thing, we can all talk about numbers from now till doomsday. Had a patient, their blood pressure was low. Their map was low. And basically I told the EMT, I said, okay, we'll put a line in just because we're supposed to. So we put the line in, and after the run, they were like, well, their map was low. And I explained to them, I said, do you know what map a paramedic needs to really, really focus in on? And I said, that's a radial pulse. If you've got a radial pulse.
Simplifying, like you said.
Everything else it's doing good. Your body is adapted, and it's perfusing your fingertips. Because we all know when you're about to, crap out, your body doesn't send blood to your fingertips. Start shunting it all toward the core to keep those vital organs alive. So if you don't have a pulse here, your map's too low. If you do have it here, it's high enough.
Finding out that information that you wanted to find out.
I'm not gonna listen to a monitor who doesn't know what the patient looks like. Monitor can't tell me what the patient's doing. It gives me a number and says people with, as I call them, eggheads, say that number should cause you to panic. I don't panic till the patient goes panic.
So let's talk about compensated and decompensated patients.
I like this.
So you start looking at that compensated patient. Everybody is trying to maintain normal homeostasis. So I want to keep normal. So if I get a fever, what do? I breathe faster. I probably don't feel the best. I might have some aches and pains and stuff like that. But that's the body's response to that type of situation. So let's look at somebody. Let's do a medical. Let's do a septic patient. So what do? Okay, they may have a fever. It's called a Vancampism. Okay, learned this many years ago. Mr. Stimpson, remember one thing. We walk into a nursing home. If they're sick, they don't know from an unknown etiology. They're septic until proven otherwise. Mr. Vancamp is spot on. Okay, there's a reason for that. Prove to me that you don't have it. We're already saying you're septic. Okay, let's get in that mindset. So let's look at the septic patient. What do we expect respiratory rate to be? We expect it to be fast. Why? They're trying to compensate. Why? Because they have the buildup of acid, lactic acidosis. It's pretty simple, but they're breathing fast. Then they go from compensated to decompensated where they can't oxygenate and ventilate themselves well. And they're failing. The vitals are starting to trend downward. What's the patient telling me by not saying anything? So we look at that. And it's like, okay, what do we need to do? What do I need to intervene to do to make this patient more stable? Because they're becoming unstable. And so the first thing we do is like, we're ventilating them. Now they're unresponsive. We got to intubate them. But what do we bag at? The problem with us at Lutheran is we have ventilators on our helicopter and our ground trucks. What do you normally breathe? What do you think you breathe? 12?
12, yeah.
About 12 a minute. So would you hook them up to 12 a minute? Would that be okay with you?
No, not with what's going on with that patient.
Okay, what would you think would be appropriate?
You want to hyperventilate a little bit.
Correct. Exactly. So Caitlin's spot on. And she wasn't prompted because I'm off the cuff when I talk.
Yeah, I was going to say.
Is you want to make sure that we maintain the compensatory mechanism that was in place by the person. And a lot of people over the years, the good thing with EMS is we overventilate everybody. If you have a BBM, every around Thanksgiving, old man Macy from the Macy's Day Parade, they're looking for the best people to help them blow up them balloons. So we find the people that bag the
I was wondering
fastest.
where you were going with that.
Okay, and I've said that for years.
That's funny.
But stop and think about that. So hyperventilation should be what? I want to bag somebody probably 18 to 20 a minute or even faster than that. And I want to have a little bit lower tidal volume because my minute volume is going to be a lot higher. I don't want to have all this medical
Pressure.
gas and pressure in my chest because what happens? I overventilate somebody with, like, say, 800 or 900 tidal volume out of a BVM because we know a BVM's got a tidal volume between what? 12 to 1700 mLs. So if you squeeze it really tight, you're probably over 1,000 on each ventilation. So increase interthoracic pressure, what does that do to cardiac output? Decreases it, exactly. So we need to understand those things to be able to think that through our head and say, okay, we need to be hyper-focused on ventilation. We really want to coordinate our ventilation. We want to be faster, but I want to look at end tidal. Where's my end tidal? Because you can have somebody that's acidotic and their end tidal is going to be low, and they could be breathing at 14, 15 times a minute, and they're in the low 20s. And I'm like, oh, what's going on? They're telling it's reading acid. Remember, end tidal is a mark of perfusion. So it's going to tell you if you're hypovolemic from hemorrhagic shock, you have low volume, low circulating blood volume, your end tidal is going to be lower. It's telling you something. That's a mark of perfusion. That's why end tidal's where it's at. EMS, we've captured it. Rock and roll. We've done phenomenal with it. In-house and hospitals, where do we stand with that at, Mr. Vancamp?
Well, if you go with the ER, that number is just basically brushed aside. Respiratory comes in, sets the vent, walks away. And they have parameters that they set that vent to. When you guys were on the streets, how many times did you estimate a blood pressure?
And the password would be more than one time.
Oh, as far as like oscillating or being like
No.
feeling.
Did you just kind of look at that person and go, I think it's 120 over 70?
Oh, yeah, now I
No.
know what you're getting.
Never did.
No.
How many times did you estimate the respiratory rate?
All the time.
A little bit at the entry
Yeah.
of my career. Like when you start, the path of least resistance is to do what everyone else does, I think.
Absolutely. Spot on.
And so, yeah, no, I would
Okay.
definitely
So when you're-
admit
when
that I
you're-
started doing that.
When you're a
initially.
septic patient, what changes first, your respiratory rate or your blood pressure?
Your respiratory rate.
It's kind of funny how what we had always taught new people when we were new. Oh, you just guesstimate that. Just guesstimate.
Right, though. That's your clue to your patient
Yeah.
who might not be obvious, but if you just slow down and look when they're not telling you, oh, they're breathing kind of quick. Wonder why.
Yeah.
Maybe we should dig a little deeper.
And you hit the nail on the head. I wonder why. I wonder why they're telling
What's
us
causing
something.
this?
Exactly. Then you look at the trauma patient. The same thing. They're hypovolemic because they're bleeding internally, and you have non-compressible shock on somebody. It's like, what do I need to do? Well, Tross carrying blood. Do I stay and wait for the blood? Do I go? Those are decisions that are going to be made by you guys. It's not going to be, well, Tony and Barry said this is what they would do. That's not what this is about. But it's about assessment and having that good clinical knowledge base up in your noggin that you're going to apply and say, okay, here's my format I'm going to go through. They're breathing fast, they're doing this. And I tell people, they're like, oh, I could take the Bob Page class and I can get 2 hours of, he can talk about end tidal. I can tell you about end tidal in about 3 minutes. Anything above 50, I tell people they're hypoxic until proven otherwise. Give them some O2, then try and figure out what's going on. If their end tidal's, say it's 30 or below, okay, they have a compensatory problem. They're trying to compensate. They're telling you something. Figure it out. Look at their respirations. So I tie that into respirations. Are they in shock? Is it because of low volume? What's causing this to be low? You've got to figure that out. But if they're a medical patient, they're breathing fast, they're septic until proven otherwise, I could care less. Look, let's talk about PE. Remember our PE run up at near DuPont?
That you're talking that young
26-year-old female. Yep.
comes walking out of the doctor's office, and she's just happened to have shorts on. We roll up. You can see the panic in her face. She's pale, and her legs are mottled. The fire department, you guys were on scene first, and her respiratory rate is probably about 32, 36. And he and I are like, oh, crap. We get out. We hear one of the EMTs on the truck, calm down, slow your breathing down.
Yeah.
And I have to say this, I'm going to interrupt him. And Mr. Vancamp looks at her and says, sweetheart, breathe as fast as you need to breathe. Keep breathing. Just keep breathing.
Yeah, we get her on the cot, we get going. And this EMT comes up and says, what did you guys see? I said, I think she's got a PE. I said, you can tell that modeling and that. We got this girl at the hospital. The doctor says, well, you got two choices. None of them are good. He says, we can do nothing. You got a 50-50 shot of living. We can go in and try and to retrieve that clot, and you got a 50-50 chance of living.
You lived.
Yeah.
And the ideology behind that was, some of the questions we were asking right off the get-go is, she's 26 years old. I said, are you on birth control? Yes. Do you smoke? Yes. Okay. Lung sounds are clear. She's got chest pain. Lung sounds are clear. I'm like, she's modeled. She's a PE. She had a saddle PE, and she lived to tell about it. We were at the entrance of DuPont Hospital out on the roadway, called for medical control approval to go to Lutheran. This before Parkview Regional was ever built. It's like we need to get her somewhere where she's going to have intervention or she's going to die, and she's going to die really quick.
She decompensate for you at all? I always hate PE calls because I have nothing in my toolbox for you. You need that removed. You have a physical barrier that is prohibiting oxygenation.
It's a shunt problem. So realize the exchange of gases occurs down in the alveoli between, the pulmonary artery and pulmonary vein. The artery is bringing it in low in oxygen. It just doesn't have the exchange of gases because that's where the clots normally falls over that area. So you don't have that gas exchange. So they become more, they have cellular hypoxia and stuff like that. But I'm going to go back to what you said, that there's nothing I can do for you. Yes, there is. Number one is you got to make that determination, which you did, and say, hey, this is going on. These are the things I'm going to do for you. We're going to get en route.
Gasoline, yeah.
We're going to get en route, number one, quickly, and I'll do interventions en route. But also, I'm going to take you to the right facility because you need interventional radiology.
That
And that's
early
huge.
notification too.
It's
'Cause
huge.
Again, we can get those rooms that she needs. We can get those help.
So if you call, stop and think. Everybody out in podcast land today, stop and think about this. You think you've got a PE, you need to get on the blower yesterday, and you need to be talking to the hospital. Because say, for instance, at Parkview and or Lutheran, if those IR labs are busy with one of their interventionalists, they're going to redirect you somewhere else. Hey, be advised, we're going to redirect you to another IR facility. So if Lutheran's busy, you're going to Parkview. We've transported patients from our facility at Lutheran up to Parkview for that reason. So if you wait till you're 2 minutes out, guess what? How have we helped the patient? We haven't. Like Barry said, early notification on this type of stuff is so important.
When you're backed into a corner as a paramedic, like I have nothing, and I have very limited tools in my toolbox for you, but there's always a choice. Like, okay, I have what I have. I guess if all I have is gasoline and communication, that's what I'm going to do, and I'm going to do it really well.
Yeah. And, some of what helps tremendously, and Tony, you can attest to this, when you get into the hospital side of things, you learn things that they need to know that we're never taught. Why do they care how far away you are? It should be just that they're coming. That way we can prepare. We need a heads up. We can call cath lab. We can call surgery. You know how quick it is to get emergent surgery on a Sunday afternoon?
Not quick.
It ain't quick at all. They got, I think Lutheran gives them like 20 minutes to a half hour to get in. You can lose a crap ton of blood in that time.
Well, and we look at that. So let's talk about that trauma, that non-compressible type trauma, where once again, it's like we got diesel or gasoline. Let's get going. What are the things that I need to be doing to support that patient? A little bit of fluid's not going to hurt them. We talk about permissive hypotension all the time and how important that is. Because remember, back in the day, it's like, oh, we're going to give them 2 units of blood. We're on the helicopter, we're going to do this, we're going to do that, and their pressure's 120/80. You have non-compressible trauma. You got 2 units of blood, they're already in, and guess what? You gave them TXA, goody gumdrops. At the end of the day, they're still bleeding. You just increase the pressure so they're going to bleed out quicker. So when they talk about permissive hypotension, if that pressure's lower, they're not going to bleed as quickly. And I'm here to tell you, once again, podcast world, keep your patient warm. You cannot do enough to keep somebody warm. When you have patients and their trauma, they're already going to be struggling. They're going to be hemodynamically on the borderline of compensated to decompensated, and you don't take the time to keep them warm, or you're going to get them trauma naked. And then you lay them on an ice cold backboard. Get them off the board as an extrication device. Throw them in a collar and call it good. How am I supporting their airway? But keeping them warm, if they get what's called coagulopathic, and Dr. Pullman once again said this, and he says he's seen it, and I've talked to other surgeons to validate that, not that I don't believe him. Your temp gets down to about 93. Guess what? You lose your ability to clot your blood because you're cold. We need to keep people warm. This isn't a paramedic thing. This is an EMR. This is a bystander thing. How many times you get to a scene if you show up somewhere and you got a bystander there and they threw a blanket on somebody?
Yeah.
They were wrecked. But yet we get there and what do?
We take it off.
We take it off. I'm like, what are we trying to accomplish here? In temperature gradients from laying down, lay on the cot and see what the turn on the heat and see what the temperature difference is. Because we're all standing up. First thing I say, hey, fat boy needs the heat off because I'm like dying in here.
Yeah, I can't work in this heat. Well, they can't live in this chill. And you have to look at it this way. More people die from cold than they do from the heat. So, I mean, it's classic. We're back to this again. And that is, we're blowing the heat from the ceiling. You stand up, you're hot, you go down, and you're like, ooh, it's chilly down here. In our trucks, I bet you there's every bit of a 15 to 20 different temperature gradient from
That's actually a good point.
when you're standing up to when you're laying down. And then, those people who, throw the blanket on top of somebody, when you're laying on that cold ground, where do you think that heat's going? Do you think it's going up or you think it's going down? That heat's going down. Number one, the earth is sucking that heat, and your body's going to try to get that earth as warm as itself.
Yeah, the earth is using your body to warm it.
Isn't that called thermodynamics or something like this? Those properties, and throwing a blanket on top of somebody.
Driver, I don't know the smart words.
That really isn't doing much. It would almost be better if you got the blanket on top or underneath them.
So remember, another thing is, if you're not shivering, you're not producing anything to increase your body temperature. So you get hyperthermic, somebody that's hyperthermic, you don't want them to shiver because that's going to increase their temperature. But you get these hypothermic patients, everybody thinks, I'm going to throw a blanket on them, they're going to get warmer. No, they're not. What's going to happen is they're going to maintain what they have. Okay, so warm fluid, stuff like that, there's certain things that you need to have in place. It's kind of twofold because you can use it, but I had a kid that was drowning, didn't intubate her, but she was super cold and she did well. The story made national news. We were up north of DuPont, and Grable at the time had paramedics, but for whatever reason, they dispatched both of us, and we beat them in. She was out on the ice. She fell through the ice. Her brother saw her, hollered for dad, and then the brother went out on the ice and fell through, and he grabbed her. She was underneath the water for probably 3 to 5 minutes, somewhere in there, and it's cold. So we get there. I get to the back. Grable's little grass pump is there, and Ray Easterly was there. And he's like, oh, we just got her out. And she's cold. We need oxygen. I said, no, we don't. And then I said a few other choice words that if you know Tony Stimpson, you know what those words.
I can only imagine, Tony.
And I'm like, we need to drive to the truck right now. And I was very insistent on that. Yeah. Got to the truck, got her stripped down, got a blanket, said picked her up. And she's probably breathing at 4 times a minute. I was working with Ian Case at the time, said get an IO. I'm just going to bag her, but I said we got to get her wet clothes off of her. And then Grable showed up and they said, what do you need? I said, I want all your warm fluid. And all I did is take that warm fluid and I packed it around her to try and warm her up. We had to have some mechanism to get her warm again. And by the time and it was way up, like I said, I don't know if it was up northeast somewhere. By the time we got to Parkview, she was starting to come around. We just supported her airway, and she was a 24-hour admit. And the kid that saved her, because Dad grabbed the kid, thinking he got a ladder and went out and grabbed the kid, his son, and thinking, oh, my daughter's underneath there. The kid never let go of the daughter. So he had a hold. When Dad pulled, he pulled them both out and never knew the daughter was there. Wow. But it made national news. It was kind of a neat little story. But it's just putting the plan together and making sure that you're doing the right thing for the right reason. And it's that hypothermia, I just can't preach about that enough, that you do the right things for the right reasons and kind of just go. Keep them warm and get the wet out, like Barry said, get the wet out from underneath them. You're doing no good.
I did want to ask you if you guys could give a piece of advice, as short or as long as you would like, for someone new in their clinical career and someone who's maybe middle or even end of their career, like what advice would you give them?
I don't think I would have one key, like, takeaway advice. There's a lot of things.
It could even be like, if someone would have told me this in my first year, man, I think that might have gone a little differently that year. Or
I had said this years ago to Tony and that kind of thing, and that is, if you take credit for the saves, then you have to take credit for the losses. I'm not willing to do that. I think this is a God thing. He puts us into places to enact his will. Don't sweat those losses, because we've all had runs that everything went perfect and we had a horrible outcome. And then we've had those runs where nothing went right and you're like, I don't understand this. How did this work? Probably 90% of the time, everybody that calls 911, we may not think it's an emergency, but to them it is.
Spot on.
Okay?
Spot on.
I've told people, the guy who built the Sears Tower, do you think he looks at building a doghouse as a project? No, because he's built the Sears Tower. So when somebody comes and says, oh, this is a problem, they don't know what we've seen. Like Dr. Pullman builds the Sears Tower. We as paramedics, we can build duplexes or whatever as an analogy. We have that knowledge. Okay, just because what you're experiencing is an emergency doesn't mean that it ranks up there on those big emergencies that we've dealt with.
So let's talk about, I'm just going to add on to what Barry's saying. Let's talk attitudinal. What type of attitude do you have for the work that you're doing? There's got to be passion. There has to be drive. You come into work, you set the tone. I'm a very routine person. My uniforms were always laid out. I pressed my shirts because I just needed to do that. That's my anal retentiveness. But I had to have two of the same pins in the pocket. They had to be the same height. And he can attest to this. He knows I'm like anal retentive about that. And to this day, I don't wear a uniform, but my clothes are laid out. Everything's ready to go for work. If it doesn't happen, I'm pissed off for the day. And it ruins my day. And I need to get, that's one of my little issues that I have.
We were very quirky. And we worked well together.
But stop and think about what I'm telling you out there is the fact that routines help. Routines can hurt, but routines can help. If you have routines on assessment and stuff like that, and you're able to vector off of those routines when you see problems, to be able to critically think through a situation, that's where it's at. You've got to be able to say, this isn't working, what do I need to do next? Or, hey, everybody stop, and I've screamed in the back of the truck, stop. Airway, breathing, circulation. We got a problem. So go ahead.
Remember, and we've had early when we were together, we would literally stop everything, take 3 breaths. Are they breathing? Yes. Is the heart beating? Yes. And all of a sudden, what was becoming chaos now just narrows down into a train on a track, because those 3 breaths really calmed you down and then to think. And remember it earlier, I had said to you, they pay us to do 3 things: airway, breathing, and circulation. And that was, we went back, we focused on that. Everything else is icing on the cake. The 2 large bore IVs and that kind of thing. Yeah, everybody would love to get that, but there's some days you can't hit the broadside of a bull's butt with a bass fiddle.
So stop and think about that. It's like what he's talking about is so true to form. Let's look at a few other things. Number 1 is always be humble. At the end of the day, you're no better than anybody else. And I just discussed this in, I don't know where, somebody's class or something, and somebody said, it was a TRA. We were doing the blood, we're helping them with the blood rollout. And Joel Bentz had told me, he said, hey, I just want to thank you for including EMTs and talking about how important they are. Well, that's not staged. I firmly believe that. At the end of the day, it doesn't matter if you're Fort Wayne Fire, you're with TRA, Grable, Northwest, Southwest, whatever it is, EMS, EIEIO, it doesn't matter. We're all on the same team. And the objective is to make the team stronger. Share those experiences so it makes the team better. I don't post a lot on Facebook. I'll repost some fire stuff and a little bit of EMS stuff. But other than that, obviously it's a stalking mechanism. Everybody knows that with a lot of people. But with that being said, you also get information off there that I'll reshare, like an EMS critical care or a fire. Look at this scene, what do you think? But at the end of the day, you got to be good to people. Because like Barry said, when somebody calls 911, they think they have a true emergency. And I tell people, we used to joke about the A-team, we're going to call the A-team, B.A. Baracus, and all these guys would come out. And then we said, oh, EMS and the fire department, we're the A-team. No, we're not. We are absolutely not.
We're a C+.
Shut up. We're not the C+ team.
C- at best.
B-, maybe. But no, stop and think about that. What do you want to come? I want the A+ team. I always want the A+ team. I want the best of the best coming for my family member, coming for me, coming for my friends. You expect that. Like I teach all over the region. I mean, I've been up in Gary and taught up there. At the end of the day, I've got to come back home. Or Barry's going up to the lakes, or Caitlin, you're driving home, or you're going to see your kids when you get off work and you crash. Somebody hits you. Do you want subpar care? No, none of us want that. So how do you get it? Dr. Matt Sutter made a statement years ago when he was our medical director at Lutheran Air, and you'll remember when I tell you this, because he beat in this airway protocol, just beat it into us and beat it into us. You got to know it. You got to know it. And somebody asked, well, how long do you do it? You train until it's boring. Train until it's boring. And I don't even talk about train. I learned something here recently, just a terminology thing. It's drill. In the fire department, we're going to go through this training. We need to drill on it. You want to do repetitions till you get it over and over and over. So we've changed things at Lutheran. We used to do some airway checkoffs. Now we do airway competencies. And we let the employees watch each other, but you're doing repetitive skill sets, that drill, that repetitiveness. On intubations, you're doing 10 with a blade, you're doing 10 with video, you're placing a supraglottic 10 times, an adult, a pediatric, and an infant. You're setting up for your difficult airway. So you get used to doing this, and this is a requirement that's done quarterly. We want that because low frequency, high risk type situations. It's like, I went to surgery and I did a couple intubations with Tony the other day and I was really good. Okay, was the patient have a volcano, airway? He's purging everything out of it. So how are we setting up to do this? What are we doing to set our employees up to make them successful? And that's what it comes down to. And Barry's got tons of stuff to share. I have tons of stuff to share. And we'll share it. But there's other people out there that are going to listen to this podcast, and I challenge every one of you to go out there and try and make an impactful difference in these EMS providers out there, because you stop and think about it. They're talking about EMS deserts now, where systems have closed down. You may wait 45 minutes for EMS response. And it's like, and you might just get a fire department with a couple EMTs or a first responder and an EMT. There's no advanced providers. Be thankful you live in northeastern Indiana. I mean, Dr. Eric Yazel, State EMS Medical Director, good friend of mine. He's an easy, good talk, funny guy. He says, you guys are sitting well in northeastern Indiana. He says, people can learn a lot from what you're doing up here. So we are doing good things. When you get that, that's what we call validation. But you know what? There's always room for improvement to do a better job.
Going back to the humble, one of the things that just sticks in my mind, Tony's brother was like a top shelf clinician. Like this guy could put an IV in a varicose vein on a gnat's hind leg. Okay. And our boss, Craig, said, I got a stack of complaint calls this thick. And he showed about a 2-inch finger. And he goes, no.
Let's go back and say an employee.
He was a goof, okay? A goof. Had a stack 2 inches thick of people saying he's the most wonderful paramedic they've ever encountered. Didn't know his job.
Clinically?
Horrible. Yeah, horrible.
Really nice to people, though, I assume.
Yeah.
But what does that tell you?
Yeah.
You're just nice to people. It doesn't matter what kind of care you give.
Exactly.
Yeah, it's that old adage.
You realize
they don't care how much you know until they know how much you care.
Some of our funnies that
I'm sure you've come across some.
The one that sticks in my mind is the time we were talking like hillbillies in the back of the truck.
No,
with the
we
patient?
At the patient's house, and we did the NASCAR paramedic routine. Back in the day, he doesn't do it anymore. Okay. Back in the day, we did the NASCAR paramedic routine, showed up at somebody's house, and it was Barry's patient. And so, I'm in there, I'm getting information. He's talking, hey, how you doing there, dude? Just kind of with our kind of Southern dialogue.
Yeah.
Yeah.
And guess what happens?
So we're talking, and it was, of course, the Hazard County, Kentucky, the Dukes of Hazzard.
So just to be clear, you guys are like, you have a prearranged agreement. You're going to go into this call talking a certain way.
We're going to talk like this all the time now, by God.
Oh, yeah.
Okay.
Dude, we had there was, as I tell people, there's a whole neighborhood up here in this head of mine all talking at the same time. But I think Tony says, my partner's from Hazard, Kentucky. Where are you from?
Oh, no.
This guy's eyes light up. I'm from Hazard, too.
So guess what happens? So he talks like a Southerner. So the routine has to go the entire time to the
All
hospital
the way to the end.
with an Ihern report and everything. The whole thing. And they're like, hey, what's going on? And Barry's like talking to the nurses. And I'm like, and normally Tony doesn't shut up for loving her money, but I didn't say a word because I'm like, oh, this is not going to go well. And they get out and it's like, hey, see you later. And Barry says, well, I was having, and I can't even recall. It's been
I don't even know how. I was like, well, yeah, I think I left her when I was a little kid, so I don't remember much about the places down there. Because this guy wanted to talk about restaurants and all
What
this other
street
stuff.
did you live?
And guess what? We didn't have back in the day. Cell phones. We can't. Yep.
Yeah.
What's the restaurant down there?
Yeah.
It was crazy. So
We had that, and then probably
That's awesome.
some of the difficult runs. You'll stop and you think and you look back and you say, what just happened here? We made a run with a little guy. I think what he was.
yeah, that.
How old was he? 8 or a little?
Yeah, he was like 8.
So we had this kid we brought down from DuPont to Lutheran, and I tried to intubate him, and I could not get him tubed, and I just kept digging, and that's before we really
He had this little guy was like a train wreck of
medical problems.
congenital issues.
Yes.
And he would develop these issues where
What do you have?
like,
Cystic fibrosis.
he had cystic fibrosis and he had a million other things. But he would start to choke.
Mm-hmm.
Okay, and he couldn't breathe. Sats would drop. The kid has been on the vent like 3-4 times a year. As we're talking to mom, these folks went from a middle class family with him to almost well, in fact, they did file bankruptcy at one point.
Living in a trailer
Yeah.
in Fort Wayne, and it was horrible. And we got to know him. We transported him. I couldn't get him tubed. I felt like crap because to me, I was beyond, I missed the tube. I'm mad at myself. I failed the patient, and it really bothered me. And then a week later, he's home, and it's probably 20 below zero outside. And we get called down to the southwest side of town to their trailer, and he's dead. So we walk in, didn't know for sure, whatever. And as soon as we walk in, we see his brother sitting there, 2-piece pajamas. And this runs, probably 20 plus years ago?
Oh, more than that, probably.
25.
Yeah.
And so we walk in and see mom and dad, see his brother, and this little guy's in the bedroom. And it's like, this is horrible. They have no running water because it's frozen. And all dad can say is, just bear with me here. I want to carry my son out to the Hearst. So we watched him do that. We called, said, we're back in service, but we're out of service. We need to make the base. Can you advise? Negative, have a supervisor there. And we were out of service for hours.
One of the details of this, too, is mom and dad had made a very difficult decision. This kid was never going to get better. Okay?
Yeah.
He's constantly doing this. He has this situation. Dad lays down in bed with him and holds his son.
Oh, yeah, that's right.
As he passes away. Okay, now, a week ago, we're fighting for this little guy. Now the family has come to the conclusion, is this a nice quality of life for this young man? And as a father, both of his fathers had kids similar to that age. Mm-hmm. We're both going, could we have done that? And the police officer that was there, this is another thing that kind of sticks in my mind, is the police officer was questioning whether or not they should investigate the family for not calling 911. And both he and I were like,
we advocated really
big
hard
for them. Because, again, and I don't think there might have been a fraction of a percentage where they're thinking to themselves, we can get out from under this. But to know that your child suffers like that and it's never going to get better, to have the fortitude to be with him is, he leaves this place. And that was super difficult for us.
And we're obviously, you've noticed that we talk a lot between the two of us back and forth in this podcast. Other than talking on the radio, and this was in the Waynedale area, and the base was downtown, we didn't say a word. We drove to the base. They called somebody in. They bought us lunch. What do you want to do? You know what I did for 3 hours? Pushed a broom. That was at the old base.
Yeah.
Where the ice skating rink is at. That's all I wanted to do, is just I needed time to process. And so stop and think about that when you're out there, and say you're training somebody for whatever reason, and they get into a situation where it's been a tough call. Everybody processes differently. To me, as a veteran employee or somebody that's been in EMS for a while, you need to be able to see that and identify that they're in need. They're maybe not in crisis, but there's a problem. And then we had a guy that worked with us. Every run he had was this critical.
Debriefed.
Yep, he needed to be debriefed, and it was this big thing. And I get it, but some of it was just compost. But at the end of the day, everybody processes differently. I think there's assistance out there. I mean, I can think back, and I still track it. I've had over 50 fire-related fatalities in my EMS and fire career, and not any one of them was easy. Unfortunately, how we process, stop and think, every once in a while that trap door in your head opens up, and it's like, this has nothing to do with anything. Why did this happen? And you have to process it. Goofy runs trigger goofy things. So you got to work through it. I talk about safe people, and I'm not a big counselor guy. I want somebody that's been in the trenches that understands what I'm talking about. So I might say call Barry, or I'll call somebody else and say, hey, I just need to talk. I need to vent. This is what's going on. And I just need somebody to listen. And that's sometimes what I would say our employees are, the people that we deal with at our EMS and fire and police, that we're twisted differently.
For sure. I think a lot of times with new people, they just need to hear, yeah, I was there. I know what that's like. I don't know what you're feeling, but I know what it's like. And what you're feeling is normal. And it can be just as simple as that. Just to know that you're not the only one that has ever had these feelings. It's like, yeah, I've had those, and I've had this. I haven't felt that. And I'm like, you will. Don't worry, you will. And then a couple weeks later, they come back and they go, you were right. Yeah, I'm not saying we're the same, but, this road leads to these towns.
Certain stops along this route.
Yep, you're going to have anger, depression, sadness, fatigue. All those little towns are on that road.
And you visit them all.
Yep.
At one time or another.
Some of them are bigger than others, and some of them are smaller.
So Kenny Hendricks worked for TRAW forever. And Patsy Hendricks was a behavioral nurse over at Parkview. But they're the ones that basically started the Northeastern Indiana Critical Stress Team, the Incident Crisis Team. But she always said something that kind of stuck out, and she's right. So remember, for these situations that are high stress and you're struggling, it's a normal reaction to an abnormal situation. Okay, so what I'm feeling is normal. It's like, I shouldn't be emotional. I shouldn't be crying. I shouldn't be doing this. I shouldn't be frustrated or mad at the situation. This is preventable. That's all a normal response because it's an abnormal situation. I'm a firm believer that we all need to be out there taking care of each other from a mental health standpoint. There's a lot of stress. EMS has changed. Like in the 8 years I've been off the streets, I see a lot of different things out there. I think EMS is trying to survive. I think there's struggles. There's a lot of things becoming more complex and who's doing what and that. But, at the end of the day, we still got to go out there and make calls. And we always bring the A+ team, and we want to be impactful and make the right decisions and critically think and still laugh and have a good time. You could stop and think about a TV show called MASH. And how did they take care of their stress? Obviously, they drank because they had the still. But really, what did they do? They laughed and they joked, and they were practical jokers. And over the years, how many practical jokes did we pull?
Oh, my gosh. millions.
Putting
You
the
know,
ambulance for sale was not the only one.
the number of people that have come through Tony and I's training at TRA, I mean, if I said it was staggering, I would probably be an understatement. Because at one point between he and I, we had trained, what was it, 3/4 of the workforce that was currently on the streets. A significant number of, the fire department's EMTs and paramedics came through with Tony and I. And people always said it was just like, you just laughed all day long. They just laughed. All they did was joke about stuff. And people say, how did you make it here so long? Well, it was always fun to come to work because he and I would 5 minutes after putting the truck in drive, we're already doing something stupid, talking silly or whatever.
But, and you get in the truck and you try and solve the world's problems, current events, what's going on, and you get sucked into gossip and stuff like that every once in a while. You got down to the base, but for the most part, it's like, it's always been fun to come to work. It's always been fun to do EMS because, it's always something different. It's fun. Yeah. You're not hanging out like and when I worked at Strick at the factory, it's like, what are you going to do there? You're going to do the same repetitive thing over and over. In EMS, nope, I'm taking care of this today. Tomorrow I'm going to deliver a baby, this, that. Everything was different. But you had to use your noggin. You had to think. It forced you to think. And I think EMS as a whole, I think they do a good job. We just have to share, like I said, you've heard me say it like 3 times now. We just have to share our knowledge base because, I'm going to be 62 next month. And it's like, I'm going to be retired at some point in time. And then, the golden years that's a golden walker and a golden wheelchair. So it's like, what do I expect out of that? What do I want to see? I wouldn't say, what do they call it? After you leave, it's what do they call that thing?
Legacy?
Your legacy. I don't have a legacy. I don't believe in legacies.
That's where I'll tell you right now that you're wrong. And
you've told me that before. I'm sensitive.
We think of legacies as something like the world knows who John Wayne is, all this other stuff. But the legacy, and I have explained this, my legacy is in Adams County because Diana was down there, you were down there, you went through training at TRA. Our legacy, Tony and I's legacy, is with the fire department now because we've trained those people. It may not be like Barry told me this in 20 years, but somebody's going to say, why do you granny wrap your cot on every patient?
Barry told me to.
I tell people, they ask, why do you do this?
Why do you do what you do?
Because of shock, It may be 87 degrees outside, but what do they call you when your body temperature is 87? Dead. That's our legacy. Nobody may ever see it. But if you look at people that write charts at TRA, you can tie that back to what Scott Gordon taught me 1987. I just perfected it and, used it here and told people this is how you're going to chart to get off the truck, and they kept it. Those are the legacies, that Tony and I have created. They'll be silent legacies, but if you knew us years down the road, you'll go, I know where that came from.
That's the bad thing about getting older. I see this and I'm like, nope, got a rant. What do you mean? I'm like, granny wrap.
Yeah.
You also do the pillow thing.
Yes, the pillow. New people will come in, you're the pillow guy. And I'm like, yeah. And it's funny because they're like, well, that seems like a lot of work. And I said, hang on. And then,
Ooh, I'm parched. All that work. Man, I might need to take
the wind's blowing. It's nasty outside. We're in the hall of a nursing home. Boom.
Yeah.
There's the next bed.
Mm-hmm.
Okay, well, what do we do with this? Put the dirty linens in the pillowcase.
Hospital gowns.
Yes.
Yeah.
Mm-hmm.
I mean, people would go crazy. Why do you guys do that? Because there's a couple of reasons. You put somebody in get them ready. If they're going to cath lab, that's before they had radial approach and they just did groin approach. It's like, get them cath lab ready. Those things that we can do to cut down the time. And I can remember the quickest cath lab times in the city was St. Joe downtown. You'd meet Louis Lopez in the ER and we'd start running down the hallway.
Yeah.
Dr. Lopez would run down the hall.
Let's go.
Yeah, you just literally bring them right in.
Yeah.
Yeah.
And open the doors and
gown, they'd move the gown up, they'd start prepping, they'd do what they needed to do. We'd be getting, if it's a STEMI, and STEMI patients, if you got a STEMI patient, why don't you have defib pads on them? There is no reason not to have defib pads on every single STEMI patient. There is no reason. There's no reason not to have them in a hospital gown. You can do so much work on your end, and there, from door to cath, or door to balloon, you decrease that time. And what does that do to that heart muscle? That saves muscle. I get goosebumps when you see the process work. And then I get mad if you get the wrong doc and they're just Mickey screwing around. It's like, this is affecting this patient's heart right now. We did our stuff. We did our diligence, but you're not doing your due diligence. And that was very frustrating. It just depended on who was on the receiving end.
So I have a question for you guys when he brought up the defib pads on the STEMIs. In ACLS, we now have this vector change. So when we do the vector change, what do they generally want us to do? They want us to go from anterior lateral to anterior posterior. Why don't we start anterior posterior? So do me a favor, when you find me down in cardiac arrest, take the extra 20 seconds, a non-beating heart, put those babies on and hit that 1 or 2 times and get it back, as to waiting 7 minutes without a pulse before you change the vector. Because, you think about it, electricity does what?
Goes to ground.
Goes to ground. So one pad is the ground, the other one's the shock, right? So if we put it anterior and lateral, and what does fat contain? Water. Electricity loves its conductors. So you may not even get that heart muscle shocked, as to where if you put it here and there, it's going to go right through it. I've had, numerous screws that I'm like, get those anterior, posterior. And they're like, okay. I said, we're not going to do vector changes in the middle of it. We're going to go right to the preferred system.
This goes back to what both of you have been saying this whole time, is just think about why you're doing what you're doing. Am I trying to follow an algorithm? Am I trying to respond to numbers on a screen? No, you went through pathology of electricity through body tissue. Okay, well, maybe this makes more sense. You're applying yourself.
Yeah.
See, that's the goal. Apply yourself. I think that's probably also why you both have gotten to where you are now, and cast a shadow. You apply yourself consistently and constantly. And I'm sure you're human. Yeah, you have off days or whatever. We all do, but it's something you are consistently doing. And
it's just like, I'm a big advocate of moving cardiac arrest too. I don't work them where I find them. Tony talks about, how the good CPR. Yeah, when you're crowded, number one, you're not going to change. You're not going to have that space. Ultimately, when we do CPR, we really want not even that 10 seconds to identify that rhythm. Now we're doing the early charges so that when you let off, hopefully, you can see the rhythm good and shock it and get right back on it. Now, when you're trying to work around a bed, furniture, all that other stuff, your quality of CPR generally isn't that great. So why not take the few extra minutes, drag them to an area where we can?
And I wouldn't even say minutes. You're looking at 30 seconds to a minute. It's like, okay, what are we doing? Somebody's doing CPR. Okay, where you at? Yep. Okay, we're going to move. Where are we going to move to? Got the living room cleared? Yep. Let's go. Boom. And other than CPR, there's nothing happening. You're getting them out. Okay, let's go. Let's go. Let's go. I've worked many arrests with Barry, and it's like, it's not complicated. It's like, it's a process. He talks about, decreasing the amount of time in between for a rhythm check. It's like pit crew CPR. Mm-hmm. They talk about it. It's out there. But, my hands are probably 2 inches, or my heels of my hands are 2 inches off the chest when they're shocking. Boom. They shock. They come up. Boom. It's like right now. What are we doing?
Yeah. And that's one of those of, is everybody clear? Yep. Up. Boom. As soon as you see that jerk, you're down. We don't care what the rhythm is immediately after the shock.
It drives me crazy. What are they? Well,
who cares?
When we check. Now is not that time.
Yeah. Start doing CPR.
But that's the good thing about the younger generation of EMS that does a really good job with that. That's one thing they do very well. It's the old dinosaur relics that have to see all this stuff. It's been hard for me to break, but it's like, nope. High quality CPR is where it's at. It has to be there. To me, that's a game changer. Early defibrillation and CPR is going to save a life.
Dr. Rob Forte always told me, he said, the biggest problem that EMS has and the reason they're not successful in their airways is they run under the stigmas. We have to intubate where we find them. He said, this is a very complicated and, teetering life and death procedure here. So why would you not take your time and do it right the first try? I can remember him hanging in the window or the sunroof of a car intubating some guy. I remember leaning into a car, tubing a guy. Okay, those are medals on our chest. We all have to sit here and go, yep, my ego came through. This is what I did today.
Yeah, but those are situations where you didn't have a choice because you couldn't get them out of the car.
Yeah.
And you weren't going to bag them appropriately. You made a decision based on what you saw.
That was old EMS. Old EMS, man, like he said, that's how we were good. You could hit every IV, but if you couldn't intubate, you were a goof. Okay? Cardiac arrest, first thing we did. What was the first thing we did on cardiac arrest?
Got to
CPR and tube them.
You didn't shock them.
No, you tubed them.
Who's patient? I got the tube.
Yeah. And then when we bag, these are the ones that kill me. We take those bags. So you wring that bag out, and as soon as it inflates, squeeze again. And that's what we did.
Things have changed so much. It's like I said, let me go back 20 plus years ago. What I know
And
now,
I'd laugh.
I'd be like, oh no, we're not going to. No.
New people, they'll talk about things. We've heard these legends of nasal intubation. He and I can tell you the stories of when the State Developmental Center was open. We would nasally intubate. What do you think? 2-3 times a week? Easily, we'd be nasally intubating these
status
seizures. Because their indication was 40 minutes of active seizure or 20 minutes of active seizure. And then after that, give the rectal diastat. If they're still seizing after 20 minutes, activate the 911 system.
Yeah. So
a puddle of slush.
And to tell you how proficient we were at it, okay, we could just pick them up, put them on the cot, start toward the hospital. And when we'd open up the doors, here's an IV, here's a tube in, there's a bag, we're cleaning up, we're getting our chart, squeeze, do. That's how.
Squeeze. Now he's telling you squeeze when I'm driving. He's in the back. We don't have anybody with us.
Yeah. That's how proficient we were at nasal intubation and how routine it was.
Yeah, we just squeeze
I'll
the bag
do it on
and
the
then
way
go
to
back
the
there.
hospital.
Yep, I'll get it. You need anything? Nope. You need fire? No, we're good.
Squeeze. Go do something else.
Okay, get in a line.
Squeeze.
Okay, I got the line.
Call
the
the
start
hospital.
the line. I have the line. I'd have the cath line in the arm. Okay, I haven't pulled it out yet. Okay, bag again. Okay, pull it out. Hook it up. Yep. Okay, put a piece of tape on it. Okay, bag again. Okay, let's get everything. Yep. You just did it as you're moving down the road.
Yeah, it was like nothing.
You took a challenge because what you were describing initially, I was like, that sounds pretty challenging. It's probably not a.
I could
super
tell you
easy
to this,
run.
I wouldn't even attempt. I'd do a surgical airway before I do a nasal tube again.
You think so?
I do not want. No, I will cut them.
You will cut them.
I will
Oh my
cut them. I
goodness.
will not do a nasal tube because how many bloody. If you get them bleeding, you got a problem.
Oh yeah,
What
the
the-
nose.
Oh,
Yeah. Oh.
So the last surgical airway I witnessed him do, it was a comedy of, I don't want to say
It's right
errors,
before I left. I was in 16.
but it's a fall.
Yeah.
Okay, it's a fall, and we cried to fall. All right.
But she needed to be crying.
So here's kind of the story. I'm down charts. It's a fall. He says, I'll go take this. So he goes in. I'm writing.
You're still in the ambulance.
Yeah,
right?
you
Yeah.
didn't even sign.
It came in as a priority 1 fall, didn't it?
Yep, and I disregarded. I walked in. I said disregard fire.
Yeah.
So they're disregarded. I walk in.
And they come out and they're like, why aren't you in there? I said, after a little bit, he comes out. He goes, well, you're going to have to help me. She wants to go to the hospital now. I'm like, okay. We get the cot out. We walk up there, sit down. And I said something to her. Hey, she talking like this. I looked at him and I said, what? He goes, what?
Yeah, she was talking normally, had fallen an hour earlier. What's going on? And she's almost like she's got starting to get a stridorous airway.
Yeah.
Yeah.
And I'm like, what is this? So we have the cot from here to not even your door.
Well,
For those listening, 10, 15 feet. I don't know. Not
Yeah.
far.
so she sits down, and I carry a Sharpie in my pocket. I said, "Ma'am, look up." And I go, and he goes,
And she's
No.
purple. Now she's purple.
and he
She's
goes,
purple.
"No." And I looked at him and I said, "You got one chance before we cut that airway." He took his one chance.
And the false vocal cords look like two ping pong balls. Had nothing set up other than grabbed a King Vision, put it in. I'm like, drop the F-bomb, and then threw the King Vision.
She's awake and conscious?
Oh, no. She's now arrested.
She went into...
Yeah,
She arrested.
And we're calling for the fire department back.
What do you guys got? I'm like, well, yeah, you can only imagine. It was pretty
So-
chaotic. But I had her crike because of Dr. Pullman. He talked about making big incisions, a couple of inches, make a big cut. Cut her, boom, got it in. We got pulses back within probably a minute and a half.
As he's cutting, I said, "Stimpson," I said, "Do you want me to get her shoes off too so you can cut down to her toenails?"
I made a big cut. I made a big ass cut.
Yeah.
And it didn't take long. We had her criked and
Yeah,
we had called St. Joe and said, hey, we're coming in
with a failed airway.
with a failed airway. And that was
Man,
it. And then
They get in here, and I'm like, "Calm down. We
We
got
think
this under
Claws
control."
out.
it's Dr. Ashurst. And
Yeah.
Oh, I'm sure he was
So
really
good old
delighted
ties.
with
And he's to this day, I see him. Like literally, I saw him like last week in the ER and said, hey, do any surgical airways? I will never forget the fact that you screwed me.
Yeah.
You screwed me out of that surgical airway. I said, no, they wanted a highly trained professional such as myself to do it, and not you, dude.
So, to make a long story short, turns out the lady fell and broke her neck, and she was bleeding, which
She had
was
a-
compressing.
She had a hematoma that
Yeah.
was swelling. It was in the anterior and the front side of her cervical spine that was swelling, and that's what was causing her her airway to close.
Yeah,
I mean, she had a totally occluded airway.
That is wild.
it was crazy. Again, a fall. There's a reason people call 911. She knew that there was an issue. Something told people know when there's an issue. People, they're not going to just, "Oh, hey, I fell."
I want to thank you guys for your time and just everything that you guys do for us and the education and all of that. So we're going to end it here. You guys just remember out there, leave it better than you found it.
Hey, how could we end it here? We haven't fixed all the world's problems yet.
We forgot to do that.
Leave it better than you found it.
That